Steve Ferries. I'm a pediatrician at Jersey Shore. Hopefully most people know me. I'm the principal investigator for the project. So we're going to go around in the room and we'll say hello to each other. And everybody who's online, if you can just put your name in the chat, that would be great. So if you can take a minute or two and put your name in the chat, that'd be very, very helpful. And we'll start with John.
I'm John Cippinelli, General Counsel for the VNA, and helping to support InCK together with Dr. Rosati and Mary Remhoff on our side. Nice to meet you all.
Hi, I'm Mary Remhoff, and I'm the Director of Early Childhood Development and Family Support and the Clinical Coordinator for the InCK program, and I'm very glad to be here with everyone.
Hi, everybody. I'm Bob Rosati. I chair the Connected Health Institute here at VNA Health Group. I'm also VP of Research and Quality. I'm working with John and Mary and several other people on this project over the last year, working specifically on the technology side. So it's nice to see everybody in person and on Zoom.
Hi, I'm Stephanie Gardner, and I'm with HMH, Hackensack Meridian Health, and I work with Dr. Carries and Barbara. I'm the program coordinator.
Hi, I'm Cindy Lynn. I work in the policy office for New Jersey Medicaid in the Department of Human Services. Barbara.
Hi, I'm Barbara Sorrell. I'm the Assistant Project Director for InCK, and I work out of HMH with Stephanie and Dr. Carey.
Hi, I'm Kathy Collins. I'm the Executive Director of Monmouth Cares, the CMO in Monmouth County.
Hi, I'm Colleen Nelson. I'm the Vice President of the Children and Family Health Institute, community-based programs here at the VNA.
My name is Joe Howe. I'm Superintendent of Schools for today in Freehold Borough.
Today?
Today?
Today. One day at a time in schools. Like in the hot. One day at a time.
Okay.
Hi, I'm Catherine Honer. I'm from the Ocean County Health Department, and I'm the Administrative Supervisor of Family Services for Special Child and Early Intervention.
Thanks everybody for making the trek to Homedale. It's really wonderful to have at least part of the in-person meeting. It's been years since we've done this. Lots happened with the project, as you well know. One more announcement: this meeting is being recorded. I'm supposed to let everybody know it's a HIPAA violation. I don't know what that means. I don't know that. And just to age myself, just what Ed Sullivan would say, we have a big show for today. So the meeting is actually going to be divided in two parts. The first part is for anybody who has any interest in InCK. Anybody in the community is invited to that. And then we do have folks that are assigned to charter. And we're going to try to have a different agenda for those folks because they're the folks that have really engaged in the governance aspect of InCK. So I appreciate everybody being here, and take a look at who's online as we get started. So I'm going to turn it over to Mary Remhoff. Just to talk about what we're going to do for the first part. We're going to discuss a very important part of the Integrated Care for Kids project, which is the whole care management piece. In many ways, that's the core of what the project is all about. So Mary's going to present that, and then we're going to have some of the community folks that have actually been engaged with InCK so far. As you know, this last year was our first year of actually trying to implement InCK. It's been a slow start, but I think we're picking up momentum. We have about almost 400 families that we're now providing services for. We hope to go in multiples of tens for next year in terms of increasing the enrollment in InCK and its services to kids. I'm going to turn it over to Mary.
Sure. Okay, I'm going to start with, as we know in InCK, there's many parts to it, and we're trying to make it as seamless as possible in order to make it comfortable. Not only.
If you could just mute your call if you're not speaking.
Yeah, John's in charge of that part of the.
So trying to make it seamless so that families can come in and go through the different sections, as well as all of our community partners and the doctors, so that we're all working together. So we are working on that. The first thing I want to do is go over the role of the Care Integration Manager. Sometimes you'll see it as CIM. Next slide. Okay. All right. The Care Integration Manager has many roles, and we call her the air traffic controller. So she works up front as a liaison with the community-based organizations and the practices, as well as she triages with certain doctors, so that families feel connected to their doctors and the doctors get the health story reports. We are setting up regions of triaging with the practices to make it more effective. We also launch, they also launch the health story for the families, and then follow up with the families and make sure that the families complete the health story so that they can do the next thing, which is completing the interview with the family that are still 2 and 3. So families, once they've completed their health story, it's married with the health complexity, and together it gives us with the medical complexity, and then it gives us a health complexity. The health complexity could be a 1, 2, or 3. The difference between the 3 is the severity and the intensity of the amount and type of risks that the family identifies when they complete their health story. So for the families that have a 2 and 3, we create integrated care plans with the rest of the parts of the InCK team. All health story reports go to the doctors, whether it's an SIL 1, 2, or 3. The doctors are given the health story report. So in a nutshell, that's what they do. They make sure that the families can come in, they get the health stories completed, they get the interviews completed, and then they make sure that the information goes back out to the doctors that they have the information. Okay, the next slide. All right, we finally put together an actual directory, a list of everybody, and it looks really great. So you'll see where the care integrations managers are. They are all on Zoom. So we have April, Meredith, Samantha is out sick, and then Erin. So they are on Zoom with us today. The other person I want to point out on here is Beth Bykow. She actually handles all the referrals coming in, and she makes sure and she verifies that the children have Medicaid. She makes sure that the spellings of the name are correct. So without Beth, we wouldn't have a system. So kudos to Beth for pulling all of the new referrals and the inquiries in together. But this is the team. So the next thing we're going to do is talk about some successes. And on Zoom is Kathy Reardon. Kathy, are you there?
I am. I'm right here.
Is there? Okay,
Can you hear
great.
me? Okay.
So I hope you had a good day at school.
It's okay.
And that the
Not over yet.
It's a little crazy these days, but.
Yep, I hear you. So thank you for coming. For me to introduce you, so Kathy Reardon is a school nurse at the Red Bank Primary School. And she has partnered with us and she makes referrals to InCK. So she's just going to tell us about that impact a little bit and getting the referrals in. And then I have a quick story about a family, and then we have some other success stories to tell you. Kathy, the floor is yours.
Okay. So when I first heard that this program was going to be up and running, I was very excited. We have a lot of families in our community that are on Medicaid and that require lots of assistance and a lot of hand-holding to help them get things that they need. They don't always know what to ask for, or even what they need. So we were thrilled to be able to have something like this. So I guess I heard more about it at the Monmouth County School Nurse Association. Mary spoke to us there. And as soon as we were able to start referring, we started referring initially the kids that had really specific needs that we knew would benefit the most, from therapies at home, parental help, scheduling, anything. So right now, I think I've personally referred probably 35. It's very easy to do. We usually have the parent with us, and I just kind of quickly do it for them, as long as they've given the okay, and then we go from there.
Good. Well, thank you. I'd like to just share a little information about one of the children, and he's a 5-year-old, and through the school nurses being able to, like Kathy said, help mom take the health story, mom could take the health story and share with her doctor and with us in care coordination all about behavioral, medical, and social determinants of health needs. So that the health story is a compiling of multiple tools so that the family at one time can tell about how she's doing herself, how her children is doing, how the child is doing that she's trying to talk about. And that way, when we get the information, we do what we call a CIM interview. So we line up the answers from the health story that mom took with an interview, and then we get a risk score, and we're able to determine what it is that mom needs. Now, what we do with this is we determine goals. So the care integration manager's role here is to talk to mom, come up with whatever the goals are, creates a care plan, and then it's going to go over into ACMT, which is our advanced care management team. But it's important that we verify all the information. So we make sure that the family and the child has a doctor, has insurance, and has some of the things that are basic needs. Once the interview is done and the goals come over, we have specific goals that are outlined by the parent. So whoever gave us the information is telling us the goals. Those are the goals we work on. So not necessarily what we feel the family should work on, but the goals that came out of their health story, which is an accumulation of both medical, behavioral, and social service. So we have pathways to put them in, and the goals that this particular mom wanted, or she wanted a home-based behavioral program for her child. She wanted things that were bilingual. She identified her barriers, which were the language, because she's Spanish-speaking, and technology, because she's not very good with it. She wanted to learn more about autism. She wanted family support. She wanted to get to know a peer that also had a child with autism, and she wanted her son to be able to engage in peer activities. So the community health worker who is bilingual then can work with mom on all these different areas and help her to get herself set up with everything. So the YMCA in Red Bank is providing a swimming program. She has bilingual services at home. Through our family support service person who is also a peer, she is a parent of a special needs child, she could work with mom and get her into family support program. So we try and put it all together for the family. I'd like to move on to another story, which
Maybe any questions first? I mean,
sure.
any questions about what's happened at the school and how that works? So it's a lot in a short period of time. Any thoughts about it?
Kathy, hi. Freehold Borough Schools here. A big hello to you down south there. Did you walk them through the health story, or did they do that on their own?
It depends. Most of our families are Hispanic, so I do sometimes our social worker or counselor will help them with it. Sometimes NJ Inc. will help them with it. We usually give them a heads up if they're going to need assistance with that. We do the initial referral without
So we try to help them with it here. I mean, with this DIM's help, or even sometimes
when I mentioned launch. So when we get the referral, it's an actual referral. So the family goes into the QR code, either by herself or with help, gets the referral form, and then it comes in. Our CIMs are responsible for outreaching directly to the family and saying, this is what we want to do with you. Do you need help? We have a few different ways that we can help the family. Either we can help the family, or like Kathy says, someone from the school could help. So a family could do it on their own, or they could get assistance in doing it.
Understood. Thank you.
And just to expand on that, the reason that we go through the whole rigmarole of QR codes, et cetera, is that we don't, all that we have currently is just a 3-year-old address, which not particularly current, doesn't really work. The managed care organization sent out some letters, we got no response, very little response from that. So it's really folks knowing them, you know, getting them to know what the program is. That's why all of you are just, to us, such an important piece of all that, about how we try to get started. And one of the reasons we've had a slow beginning is because we've been working on how to find these families, how to get them to know what InCK is. It's not only a new benefit, it's a free benefit for them. It's really a tremendous resource. And it's also population-based. So even though you probably refer kids that have a lot of need, we want anybody in Medicaid to be able to use the service. It's a global service for everybody. It's 145,000 kids in Monmouth and Ocean County with Medicaid. So we have a tremendous upside in trying to reach these families.
I don't see your elf on the shelf there, Kathy. Disappointed. I know he lost his teeth. That's what
Oh, he did.
Dr. Rome.
Today he ate a carrot today. Oops.
Very good.
Okay.
Steph, is it possible to check the chats to see if there are any questions that people are submitting in writing?
Can they be unmuted and talk? I mean, how's that work?
Yeah, they can.
So if anybody's on the line and wants to just ask a question rather than putting it in the chat, you can just ask it. I think everybody's unmuted if you have a question to bring up. Otherwise, we can.
Excuse me,
Sure.
I've been monitoring the chat. There's been no questions asked.
Okay.
Oh, thank you, Beth.
Thank you.
I'm Jenny Hurd from Red Bank with Kathy Reardon. I had a question, actually, if we can do that. My question is related to these students who we have now referred, and so what we're finding across the board is oftentimes we're not necessarily aware after the fact that the child has been placed on a tier, or again, I think I mentioned this at the last meeting, we're having to make sure that we follow up with you to be sure that you're aware of what our concerns were, because the parents in our district sometimes are not able to relay that as well as they would want to. So they need our assistance. And so when they do the full health history with you, sometimes the item that really was the central reason for us recommending referral does not come through as clearly. So I believe you mentioned the point person earlier that we should speak to follow up, perhaps, if we were supporting the referral. Is that possible, that there would be a person that we could contact?
Yes. Right now, I'm your point person, so I'm
Okay,
not doing a very good job at being Red Bank's point person, but I am working at doing better. There is someone starting in January who is bilingual and will be your point person. So so we are working on that. And that's why I put it up on the slide. The other thing is the school district or whoever the referral source is part of the care team. So it will be shared with you about the tiered system, and then you will be part of the team so that everything with family consent is shared with you so that we know what the concerns are. You'll have an opportunity to work on that. So I think.
Hey, Mary, how about access to the care management platform for folks? How does that work, or how will that work?
Right now it's verbal and email. So in the future, that care management platform will be available, but that's in the future.
What's that look like from a timing perspective?
Honestly, I don't know. I mean, we don't even have that slated for next year, to be honest with you. We can look at maybe getting it in, but that is something that can put off.
Okay.
That's absolutely okay. As long as we know that we can reach out to the point people and follow up, because we do have, it's wonderful. We have an RTI team of guidance counselors, social workers, and our nurses all working with the families and the children on this. So we're making a real concerted effort across the board of anybody who's working with someone in need. And so that's the information that I'll share back with them. I appreciate it. Thank you.
All right, Jenny, thank you. And thank you for all your hard work. You've been a definite champion for these children and for actually moving InCK along to make sure
Right.
we're serving both the community and the doctors.
Yeah, always get back to us if there's some gaps, because this, again, the whole goal is integration. The whole goal is for you to be not just part of the initial part, but be fully engaged throughout. You should know what's going on. I mean, you're part of that care management team.
If I could, this is John Chipinelli. I did want to touch on something that Jenny mentioned, which is the health story is designed to be almost exhaustive in what it looks like for a child's needs. So while you might interact with the child just in one area, when we get the child into the health story or the family into the health story and they answer the what are we up to, 40 or 60 questions in it, we get a much more complete picture of what that child could benefit from, what they're working on, what they might need some assistance in. So we really do use that health story as a way of getting the child into the system for a much more comprehensive look at the resources that could be made available to the family. But for our perspective, it's that first step, getting them into the health story, that's so critical because it opens the door basically to InCK. So while we're still building a care platform that will allow for true interoperability, it's a term that, has been thrown around probably for the past 10 years and everybody's still working on it. Getting that assessment completed, that SIL assessment, gives us a real tool for reaching back out to the family, reaching out to that family's provider, and making sure that now the care, all of the care that that child might benefit from can be coordinated.
I think we also need to note that the health story is important for the families as well, because it's so comprehensive that there's things in there that parents might never, or caregivers might never have known would impact their child's life, like the health of the mother, or there's a few other, people don't always equate housing with the child's health, and these are all factors, and we've all been very made aware of this during the pandemic, that these all factor into child's health, but it brings it to the forefront for the family as well, that maybe I need to talk to somebody about this stuff too. So it may open up a whole new set of issues that need to be addressed, but they need to get addressed.
And again, to emphasize that there's a summary of the health story that goes directly to the provider, so that they're engaged with, hopefully will be the combined medical home for these kids, and they'll be part of the process, not just of the health story and including that in their evaluation of the child, but also part of our care team. So the community health workers, et cetera, will be connecting with them. Again, the goal is to break down the silos and getting people to work together.
So we're going to actually walk people through how to enroll a family in a health story later, but for right now, we do have some other experiences that Mary's going to get us to. Yeah, sorry.
So April and Dr. Grossman, are you on the line?
We are here. Hi.
Hi. So I understand you're together?
We are. Also here with Alan McCarthy, our attack teams. Oh, we're getting a little reverb.
Let me X out. Let me get out.
There we go. We're also here with Alan McCarthy, who is our clinical coordinator for our pediatric advanced care team.
Okay, great. All right. So you're up next.
So I think, can we have the next slide, please? Okay, there we go. Perfect. So hi, everyone. Again, I'm April Slowinski. I am one of the care integration managers for the InCK program. And we were going to talk a little bit today about specifically the great relationship that InCK and the pediatric advanced care team at K. Hovnanian Children's Hospital have built. We'll talk a little bit about what that looks like, and then some great success stories. But Dr. Grossman, I don't know if you want to give just a brief overview of what PACT is.
we're so excited about being part of this team and collaborating. Our team is based in K.F. Children's Hospital. We are the Pediatric Advanced Care Team, or PACT team. And we have a robust team with a pediatric neonatologist, a full-time nurse practitioner, a full-time clinical coordinator in Allen, and a full-time social worker. And we work with kids with complex chronic conditions. So any child who needs palliation or end-of-life therapy is our catchment. And we have found that we've incorporated into our initial intake process for our unique patients, a internal checklist with our team to figure out whether or not patients are eligible. And Alan will go and meet with a new family and find out if do background check to see if they're eligible based on our medical opinion of the complexity of their illness, and then we get them to you for their stories. And the families have been very, very grateful for the intervention, and quite honestly, we've referred, I think, 20 or more families so far, but we would have referred probably double that, right, Alan? Except for the limitations on the catchment. So it's limited by the Monmouth and Ocean County right now, because we do have families coming to the hospital from all over. But we feel like it's been a great asset to our families and a great collaboration so far. So.
Yeah, so it's really been a wonderful partnership. And what's great is that the majority of the children that are being referred to InCK by the PAC team, because of their medical complexity, nearly every one of them is eligible for the InCK program. And we're able to kind of jump right in and start working with these families. Can we have the next slide, please? So to talk a little bit about the family response, and a little bit of this was discussed earlier, but overall families have been pretty receptive to the health story. And Mary had mentioned previously, once we start working with the family, the care integration managers, our role is to talk with the family about their responses to the health story, and then develop goals with them. And those goals are family driven. So based on what the family prioritizes as their top goals to start with, that's how we develop our integrated care plan. There were a couple of barriers that had been mentioned before regarding, those who have difficulty with technology, maybe some low literacy, difficulty understanding the questions on the health story. To address that, the care integration managers, we can work directly with the family to provide support as they complete the health story. So we, get consent to send them the health story, and then we hear back from them and they say, hey, I'm not understanding this, or hey, I'm not able to open this on my phone. And then we have the ability to go in through what we call the back door over the phone and actually do the health story hand in hand with the family to help them get it completed. So even though there are a couple of little hiccups, barriers, we have found ways to overcome those barriers in order to make sure that the children are getting access to the services. And then once they're enrolled, we've had really great feedback from the families. You can have the next slide. So we thought we would share, just some family stories about specifically families that were referred by the PACT team, and kind of what their medical background was that led to the referral, and then a little bit of information about the work that the InCK team has been doing so far to help the family make progress towards those goals. So for this first family, the initial referral, I think, was specifically for the infant that was in the NICU. And then later it was discovered that there were 3 older siblings who all also had medical complexities. So Dr. Grossman and Alan referred them over to us. And after completing the health story, we learned about a lot of different needs that this family had in addition to their medical needs. So based on the conversations that the CIM had, the health story, information from Dr. Grossman and Alan, and then information from the family, we worked with the family to set up what the initial goals would be. So to date, and I want to stress it's to date, because what's great about this program is it's longitudinal care coordination. So we're with these families as long as they want us and they remain eligible. So we're working towards these goals, but that doesn't mean that new goals won't show up in the future, new needs won't show up in the future. And when they're with us, we're able to kind of keep track of that and continue to add to their goals and to their pathways as new needs arise. So in this particular case, we had this family with the baby in the NICU, the 3 older siblings. We started off by connecting the family with pediatric medical daycare and early intervention, so that when the baby is discharged from the NICU, those services will already be established and in place so that they can start getting those services immediately. And there's not that wait time in between discharge for them to get those services. Another area that the family identified was housing. So our community health workers have been working with them to help them navigate the Section 8 housing, referring the older children to Big Brothers and Big Sisters programs.
Hey, we're all crazy. We're all moving too fast. I did a.
If everybody could mute their phones.
And then our family support specialist is also helping to facilitate communication between the mom and the school in the creation of individual health plans for those older children.
To jump in here to just make sure that everybody knows that these are broad stroke medical information and the patient's names are blinded to protect their privacy. But we also wanted to give you an idea of what kind of cases we have been working with. And I wanted to just jump on that first point that April made about connecting the families early and prior to discharge. This helps the hospital in making sure that we're getting safe discharges, but it really helps the family in allowing them to know that they're supported before they even leave the hospital. So it's a really nice feature.
The next slide, please. So this is another kiddo that was referred to us, Allie, as we will call her. She's a school-age child. She has a very complex medical history. I don't know if you want to share any additional details about the medical history, but she was born prematurely. She's had a lot of medical complications over the years, multiple PICU admissions, just a lot of complex medical needs. There's also 5 siblings in the home, and there's a history of domestic violence in the home as well. So some of the progress that our team has been working on with this family was making referrals to legal assistance. Our team has been working with them on housing. The mom had identified one of her biggest concerns is that an area that they relocated to is known for having a high rate of drug-related crimes. She's concerned about the children's safety. So our team is working with her, on referrals and making connections to help them get into safer housing. The team has also worked with the mom on communicating with the MCO. Mom had expressed a need for some type of mobility device, whether a stroller or a wheelchair, something along those lines that would support the child and also support the medical equipment that she needs. So our team has worked with the MCO to kind of explore what's available for her and to help advocate for that. The child life specialist on our team is working with the child and family to provide therapeutic medical play and emotional support for both the child and the siblings, that they get that long-term therapeutic medical play both in the hospital and outside of the hospital setting. And then we also provided resources for holiday gift support. That was actually a big concern of moms, which is very appropriate, around the holidays. Sometimes families don't know how they're going to provide for their children during the holidays, and we were able to help provide support there as well.
And I think it was.
April, this is John Cipanelli. One question, and this is more for Dr. Grossman. Would any of these issues have normally come up just on your interaction with the patient? What's astounding to me here is the kind of scope of services that are being addressed.
Yes, so part of what our team does is ask, our intake is like a 360-degree intake when we do a unique consult. So we do actually delve into these aspects, but we haven't had a lot of resources to do anything about it before. And so we would do one-off, try to intervene and help, and have to do everything from scratch ourselves and try and identify support systems in and out of the home. And I was going to say, with this young lady, this family, and we've been following them since birth, but I've been involved with her for the past 5 years, and they'd always been very resistant to the type of therapeutic medical play, emotional support, counseling that we've been recommending based on our understanding of what's happened and trying to provide it when she's inpatient, but knowing that there's a big gap when she goes home because the mother, for many reasons, appropriate reasons, not being able to afford it, not being able to get to the appointments, not being able to find childcare for her other children. And now she's open to it because she has access to it in her home and in a way that works for them as a family.
That is great, really great to hear. April, just in the interest of time, because we do want to be able to walk people through how to actually get families enrolled in a health story. I understand you have a few other families, but maybe if you could just kind of zip through one more, and then we'll get to Dr. Rosati and to how families can actually get enrolled.
Yeah, so we'll try to get through this one pretty quickly. So for this child, this is a child who has a rare genetic disease resulting in her having multiple seizures a day, and those seizures require her to have 24/7 supervision. There's also an older sibling in the home who's experienced a lot of significant losses. He actually experienced the death of his twin, and also 2 grandparents. And the prognosis for his sister is pretty poor. So one of the things that the family identified is, they're very concerned about how the sibling will cope with the sister's diagnosis, her treatment, and her prognosis. And there's also been a lot of concerns related to getting her home nursing care. So our team has been working to try to help mom navigate the healthcare and insurance systems to facilitate getting home nursing. It's a work in progress, but we're getting there. We're making steps. Also helping to communicate with that healthcare system and insurance for necessary adaptive equipment. And then from the child life perspective, providing that extra support for the sibling who has already experienced tremendous loss, is having a lot of emotional, challenges, and really struggling with seeing his sister having, many, many seizures every day and just not knowing what the future holds. So being able to provide that level of support to them, encompassing, that nursing piece, adaptive equipment piece, plus, not forgetting about the sibling who also needs that support. I don't know if you have anything to add. I know we're on a time crunch.
Yeah, well, I think the whole family approach is such an important part of this program because siblings often do not get the support they need, especially when they have chronically ill siblings. And so recognizing that and providing inroads for them to get support as well is such a tremendous benefit of this program as well.
Great. Dr. Grossman, thank you so very much for the time. I appreciate how busy you are, and especially appreciate the embracing of InCK and the use of the health story. And April, thank you for that. What we'd like to do is now, since the tool that we're all kind of using now to get people into InCK is the health story, we'd like to introduce Dr. Rosati just to show everybody, those on the phone, on the call as well as here, how do you actually enroll a family? Because at some point, we're going to be looking to all of you in one capacity or another to encourage enrollment. So we want you to understand what does a family actually have to do to get into a health story? Dr. Rosati?
Sure. So, next slide. So first off, I mean, you know, this is all about communication initially with the family and really having them understand that what we're going to do for them is to provide a service that's really going to get them access to community resources that, you know, typically they may not even know about, or if they do, haven't had an easy way of getting to them. So this is really what InCK is about. So next slide. So the way we've designed this is it really starts with a referral process. And this is done via what we call an interest form. I'll show you that in a second. But the way to get to that interest form is via a web link that exists, you know, it's on the website for InCK, but also you can use these QR codes, and these sheets that are in front of you have them on there. There are different versions depending on whether it's Spanish or English. So let's see, can you click on let's see if it's going to work here. Can you click on that where it says interest form?
Oh, yeah. Everybody can scan.
Right, so you could do it that way, but what this is basically doing, if it works, it may not. Oh, it did.
Yeah.
Okay. So
That was a big help.
it's loading, it's a little slower, just the way we're doing it. But basically what this does is it brings everyone to this forum that asks for basic information about the child and then some information about how to contact them. So any start fields, there are required fields. We need this information to verify whether or not the child has Medicaid, and I'll get to that in a second. And then we need some contact information, so we need to know, you know, should we reach out to you via email or cell phone? As Dr. Carey has said, we don't often have, like from the payers side of it, current information. So it's not like they can give us a list and we can just follow up with kids automatically. We have to go through this process of really verifying who these kids are. You know, do we have the right address? Do we have the right way to contact them? So if you scroll down, we want to know a little bit more about, you know, where they're living. Is it a permanent address? If they have the Medicaid ID, that's perfect for us, because once we have that number, we can quickly initiate the whole process. We do add a few more questions at the end, which were started recently, asking just basically who referred you, you know, is it an organization you're working with? We want a little bit more background information. And then scroll down, we have these final questions, and this is what Mary was alluding to. We asked, you know, do they have access to the internet? You know, on a browser on their phone? Do they have access on a computer? Because you know, this is all done electronically, so we really need to get a sense of whether they can do that. If not, we're going to have to get them to some other resources. And do they need more information about InCK? I've never seen anybody answer that question. No. So everybody needs more information that they need about InCK. And we're finding that people generally have access to the internet, so that's not really an issue. Okay, so let's go back to the slide. So that's how you get started. So next slide. That's the form in case it didn't work. And just so you know, this is our intake process. So referrals come in via the form. It's done in a product called Do Forms, just so you know that. And then what happens is that creates this referral list, and that's kind of where Beth is working. She's looking to see now, can we find out if this child has Medicaid? We not only need for eligibility, but we also need that data because we get claims information, and that's how we compute the medical complexity score. So this is where we're doing this matchup. So that's a bit of a manual process. It does occur fairly quickly, within an hour or two of us kind of getting these. She's done the verification. From there, we then go out and contact the beneficiaries. So this is where we do an outreach, and Mary's team will call them up. We'll text them if we can to say, we want to send you this health story. Are you interested in receiving it? We find that this is a little better than coldly sending out the health story, because honestly, you know, somebody's going to get a text and say, would you reply to this, or an email? They're just not going to do it. So then what happens is, if the person says, no, I don't want to participate, then we stop at that point. If they say yes, we send them the link to the health story. Hopefully, they fill it out. We do multiple attempts over about a 3-week period with reminders to get them to fill it out. Then from that point, if they never fill it out, they're kind of off the list again. If they do, they move on to the case management, depending on their level. So this is how we go through this whole process with them.
From the referral list with Beth working that, like, what would be the time frame that somebody could expect? Like, if we're talking to people, like, within 24 hours?
I would say 48 hours.
Okay.
Yeah.
Gotcha.
To be safe.
She's pretty quick right
Yeah.
now.
Yeah, that's good.
You know,
Yeah.
I'd like to add, if it was an emergent situation and you let me know that, I can have that to you, in a period of not even a half an hour and have it assigned to a care integration manager if it's an emergent situation.
Thank you.
If they're not Medicaid eligible, do you call them and say, this isn't for you?
Yes,
Yes.
we are letting families know that they're not eligible.
Yeah. And we keep track of that.
And we also call the families and let them know whether their SIL score is a 1, 2, or 3, so that they're aware.
We have some work in process to automate this referral matching to Medicaid data. It maybe be ready in a couple of months, but we're hoping that we don't have to rely on Beth to do that. We can do it in an automated way, but we're not there yet, but it's in the pipeline. Okay, next slide. So this is what the health story looks like on a phone. Most people don't do it on their phone. Well, they do it on their phone, but they don't use the app. This is actually the app view. They typically go to the web and they do it that way. It doesn't really matter. It works the same way regardless of what technology you decide. I can see where people who get the link are less likely to download an app and, wondering, am I going to do this one time? What do I need an app for, right? So they just go to the web. Slide. So just so you have a sense of what comes out of all this work, and John was alluding to this, we have this health story with all the information that gets summarized so that there's these scores at the top that basically have the medical complexity, the social complexity, and the service integration levels. They're color-coded where they're, green, yellow, red, depending on whether the level of complexity reaches a certain value. And then we have the individual subscales of the tool. Then there are a whole lot of pages after this where you can literally see every question and the response on every question. So there's this very detailed health story. The upfront piece here is probably where we think, providers are going to focus initially on and just see, where is this child on these, these particular levels of complexity, but they can certainly dig in deeper and look at that in more detail. And then next slide is just, okay, so what do you do when you want to contact us about, the whole process? You can reach out via the website, you can email us, you can also call this 800 number, and if you pick option 2, that takes you directly to the InCK program. It's recorded, so you'll hear, that option 2 is that, but it tells you that this is the way to get to us, and we do answer that call, Monday to Friday, normal business hours. Otherwise, they can leave a message and we get back to you.
Everybody have access to these slides? Everybody will get these?
Yes, we'll be sending them. So one of the important numbers for us is that as of last count, there are 150,000 children who might be eligible for these services. So you'll see the importance of getting this tool in the hands of those families it's huge. Otherwise, outreach to that many people and trying to go through their particular condition could take forever. And we're at a phase now with InCK where we're truly trying to turn this into a population health approach, where we get data on that entire body of potential beneficiaries, as well as the active care coordination and management that Mary's team provides. So we're excited about the tool, but as you can see, and I think as Dr. Grossman's experience kind of highlights, there's a lot of hand-holding at first that is required to get families comfortable with even the idea of sharing their information. So I think of it as a high-tech tool, but it still requires that kind of human touch. And it's that outreach we found in our enrollment numbers that gets families comfortable with sharing, we have the highest success rate of health story completions when there is some guidance. It's both an opportunity and sometimes a bit of a barrier, because we need that trust. But that's also where we look to all of the members of the Partnership Council and everybody who's got a stake in this. As Dr. Carries is going to talk about a little bit now, but also more for the second half of the meeting, just how vital all of you are going to be in getting this to where it really could be.
So let me just see, there are other questions. I know we're a little bit over time, but I think this is really critical. Other questions from anybody?
Just one more point I would like to add about what Dr.
Sure.
Rosati said about the interest form and any of the inquiries, contact information coming through the website. We do have InCK members frequently checking the website inquiries, all the questions that come in. So it is really a good platform to, give your families, let them know that if they need to contact us, please go through the website. There are people on the receiving end addressing those questions. Thanks.
Just the last thing to bring up before we have to switch out is that if anybody, either in the audience, in the cyberspace or here live, would like us to come in either by Zoom or whatever, just talk to your whole organization about this. I know you're one person representing a large organization, since many of the potential referrers might come from other folks in your organization. We'd be more than happy to do that because we think, as we've said, that your involvement is really critical to us. These are families that know you well, know you best, and if a trusted person is the person referring to us, I think we'll have a much higher, rate of receptivity. So, you have our numbers, you know how to contact us. You can email us, and we'll get back to you as quickly as we can. So thank you all for being on the call. We were going to try now to just meet with the charter members, but that's been a part of InCK that we've never really done enough with yet in terms of getting them truly involved in the governing aspects of the project. So any last questions before we move on? So thank you so much for being a part of us. It's been a great audience. Thank you so much.
Thanks, everyone. Thank
Stephanie,
you
how
very
do we
much.
switch to part
Yes.
B?
Thank you.
Thank you for
Just
coming.
anybody who's guided, there'll be another Zoom for those who who are the partners.
We know, everybody knows how that works? I don't.